Hello, everyone. This is Mary Ann Gandy, the Assistant Director of Provider Education at the Association of Community Cancer Centers. I want to thank you for joining us in today's webinar, Molecular Testing, the Tissue Issue, Sampling and Testing, as part of the Molecular Testing Peer-to-Peer webinar series. Funding and support for this series was provided by Pfizer Oncology. This webinar will be presented by Dr. Joe Kim and will feature Dr. Pablo Gutman. Dr. Gutman is the Department Chair for Pathology at Holy Cross Germantown Hospital and Medical Director of the Cancer Institute Holy Cross Health. He's been a leader in process improvement initiatives for molecular testing at his institution. Dr. Kim is President of Medical Communications Media. At this time, I will turn the session over to Dr. Kim.
Great. Thank you very much, Mary Ann, and it's a pleasure to be here. So we are going to be talking about the whole molecular testing, biomarker testing in lung cancer. And to get us started, I want to set the stage by mentioning that in 2014, we were involved in a project with ACCC around this topic of biomarker testing. And we worked closely with a number of different community cancer programs. And this collaboration was supported by Pfizer. Each of the programs took a look at their own cancer registry, looked into their electronic health records, and from there extracted their baseline performance on biomarker testing. And then we went in and conducted these learning labs. And throughout this entire initiative, it was really interesting to just get perspectives from all these different centers around the country. And based on the information that we collected and the things that we discussed, we developed a series of these improvement plans. So joining me is Dr. Gutman, who has already been introduced. But Dr. Gutman, I'd like you to just tell the audience a little bit about your program as well as your role within your institution, if you would.
Sure, Joe. Thanks for the invitation. Our institution is a two-hospital system, a part of Holy Cross Health, right outside of Washington, D.C. Between the two hospitals, there's 600 beds with about 1,500 to 1,800 newly diagnosed cases of cancer every year. We are accredited as a cancer center, and we, of course, very much appreciate the opportunity to participate and learn in initiatives that have to do with cancer diagnosis and treatment.
Great. Thank you very much. So returning now to these learning lab projects that we did back in 2014, preceding this were a series of other quality improvement workshops that included Holy Cross Hospital. And so there have been a number of these community-based cancer programs that have now participated in quality improvement processes around biomarker testing in lung. The Learning Lab project specifically involved these 8 community programs. You'll see that they are spread out all over the country. And some of these are significantly larger hospitals or cancer programs than others. And on this slide here, you'll actually see that when we group these 8 programs into those who treated over 100 lung adenocarcinoma patients a year versus those that treated less than 100, you'll see that the EGFR and ALK testing rates during that baseline period of 2012, mostly 2013, range anywhere from a 52 to 62% EGFR testing rate as well as a 47 to 60% ALK testing rate. Now, we've gone in and we've worked with these centers to improve those numbers, but to get this baseline, they had to look into their cancer registry, see how many lung cancer patients they're treating as well as the disease stage, and then from there look into the actual pathology reports and electronic records to see what the actual testing rates were. We had all the centers, when we conducted these learning labs, have interdisciplinary discussions around why the testing rates were what they were, as well as explore what we could do to improve that. So here, you'll see that the objectives of this webinar is to evaluate and discuss how the teams of cancer, in the cancer treatment team, oncologists, pathologists, the pulmonologists and radiologists performing the biopsies, the surgeons, how all of them can collectively work together with the proper leadership and guidance to form policies and procedures, as well as to really establish consensus and buy-in on how they can improve these processes so that they can ultimately improve the treatment of patients with lung cancer. And so we're going to be talking about some of the lessons that we learned from the learning labs, as well as some of the other initiatives that have followed on since then, and share some of those insights with you. Now, just to set the stage, in 2013, the College of American Pathologists, CAP, the International Association for the Study of Lung Cancer, IASLC, and the Association for Molecular Pathology, or AMP, released guidelines on the molecular testing for lung cancer patients, as well as the use of these EGFR and ALK tyrosine kinase inhibitors. Earlier this year, in January, these three organizations announced that they are going to be updating these guidelines to address evolving issues such as the ALK testing recommendations, EGFR and ALK resistance issues, emerging molecular targets, as well as the need to rebiopsy, especially in the setting of post-treatment relapse. So we can expect additional information and announcements from these organizations, but currently I would say that most of the consensus and the processes that have been established have really been focused around these 2013 guidelines. We also know that non-small cell lung cancer is a heterogeneous disease, and back in 1987, we really didn't have a lot of information about the various mutations and the molecular markers. Fast forward to 2004, and we knew about things like KRAS and EGFR, but we also knew that there were all these unknown biomarkers out there. And in 2013, we see that there are a number on this pie chart ranging from KRAS, EGFR, ALK, and a host of others. And so now, in today's environment, most community cancer programs are certainly testing for EGFR and ALK because they are FDA-approved therapies, but there's also ongoing clinical studies evaluating a host of others, and we need to evaluate and consider what is most relevant for our clinicians for the patient populations that we serve. So going back to those 2013 guidelines, Section 1, Question 2, there's a key point here that says, when should a patient specimen be tested for EGFR mutation or ALK rearrangement? And based on the recommendations and the suggestions that are listed here regarding the advanced stage disease, as well as patients who are suitable for treatment, we established processes and pathways at each of these centers by having discussions around how they are handling these issues. One of them, for instance, might be that when the pathologist receives the biopsy and they acknowledge that it's stage 4 adenocarcinoma of the lung, then at that point they perhaps might reflexively test for EGFR and ALK. Other centers might have taken a slightly modified approach from that. So we examined these guidelines, we thought about and we discussed what are some processes that can practically be applied within each of the centers, understanding their resources, their pathways, and the ways that the various clinicians communicate, and we use this really as the backbone. Now, some of the key barriers that we came across, despite whatever the guidelines may say, or despite how the teams of clinicians were performing biopsies, a common barrier that just came up over and over across all of these different programs was that oftentimes the samples are just insufficient for biomarker testing. You may have enough tissue to establish a diagnosis, but you don't have enough for that EGFR or ALK testing, or in some cases, if the medical oncologist insisted on further testing, there just wasn't enough tissue. And part of the reasons are because in many cases the diagnosis is being performed using a fine needle aspiration, or FNA. In other cases, a radiologist might be doing a percutaneous CT-guided core needle biopsy, and many of these organizations lacked the resources to have rapid on-site evaluation or ROSE by either a pathologist or a cytotechnician. So we had a lot of time discussing with the pulmonologists, radiologists, and surgeons around ways that they can improve their methods to ensure that there's enough sample. And Dr. Gutman, I guess I wanted to just get your insights on how has Holy Cross addressed this issue of inadequate samples, and can you just share with us, the role of your pulmonologists, the radiologists, the surgeons in this area?
Of course. So in our situation, we have tissue coming from various sources. Our pulmonologists are the individuals doing our EBISs. Our radiologists are the ones doing the CT-guided biopsies, and our surgeons, of course, are doing their open procedures. But in addition to that, about a year and a half ago, we acquired navigation node bronchoscopy capabilities. So we are also getting very small amounts of tissue from these navigational bronchoscopy type procedures. What we realized very quickly, because all of these, or most of these sources of tissue give very limited amounts of material, is that if we did not put a protocol in place very quickly, as you said, we might be able to make that initial diagnosis, and many times limiting the diagnosis to non-small cell carcinoma versus small cell carcinoma. But many, many years ago, that clearly became not sufficient, and nowadays I think is pretty much unacceptable. So we needed to work in a multidisciplinary fashion with the different departments to assure that in pathology eventually we would receive enough tissue not only for diagnosis but for proper classification of the tumor, and after proper classification of the tumor for molecular testing.
Great, thank you. Another key barrier that we addressed when we went out to these 8 programs and conducted these learning labs was that molecular biomarker testing is often either delayed or completely forgotten. And I think the completely forgotten is rare, but certainly the delay was a very common theme. In some cases, physicians did forget to order the tests, and they just continued on with their treatment plans. But in many cases, what would happen is that the biopsy might get performed, say, on June 1st, and then the medical oncologist might see that patient a week or 2 later, and at that point, they decide that, all right, well, you've got stage 4 advanced adenocarcinoma of the lung, so why don't we send off your sample for EGFR and ALK testing, and then it takes a few more days for that order to get processed, and then an additional potentially 2 weeks for the results to come back. So we were spending a lot of time asking these different cancer programs, what can be done to reduce those delays? Is there a process that can potentially be put into place, whether it's a pathology-driven reflexive testing or something else? And we explored a lot of different options, and we'll talk about some of those things in a moment. The other source of delay that we ran into, it didn't happen too frequently, but occasionally, many of these programs would tell us that, yeah, occasionally we will biopsy a patient who's admitted into the hospital, and they get the diagnosis of lung cancer as an inpatient. Now, due to the Medicare 14-day rule, if we then send that sample off for biomarker testing, we won't get reimbursed if that test is performed while the patient is still admitted. So we have to wait till the patient gets discharged, wait 14 days, and then send off the sample for testing. Are there ways that hospitals can address these issues more proactively so that we don't always have to deal with these things in a case-by-case scenario? So there were various issues as well as others like waiting for the tumor staging, or even just some disagreements and controversy around which molecular biomarker test to order. Should it just be limited to EGFR and ALK? Should it be a broader panel? And these were all, what we found was every institution took a different approach, but they took an approach that eventually established consensus for their team so that they can achieve that level of efficiency. And Dr. Gutman, if you could just comment on some of these things in terms of how your organization has handled it, that would be great for the audience to hear.
Sure. So for us, because of the way that our physician practices work with the hospital, and that being said, the physicians are not employed by our hospital system. There are different oncology groups. There are different thoracic surgery groups. There are different radiation therapy groups. It becomes very difficult for us to adapt to the different ways in which different groups would want to practice or would prefer to practice. So what we did with the help of ACCC and you, Joe, is we brought all the players into the room from the different practices, from the different specialties, and we came up with a consensus as to how we were going to obtain this tissue, how it was going to be submitted to pathology, how pathology would treat this tissue, how molecular studies would be ordered, etc. To summarize all these steps, we decided, and this is the way we've been working for the last 1.5 to 2 years, that all non-small cell, non-squamous cell carcinomas of the lung that were diagnosed in our Department of Pathology would be sent for molecular testing. And although we do test, quote-unquote, unnecessarily in some instances, because, as we know, stage 1, stage 2 tumors, most stage 3 tumors may not need testing at the time of diagnosis, we found that if we waited to find out who the oncologist treating the patient would be, And that sometimes an oncologist doesn't even belong to our hospital system. There would be significant delays in ordering and receiving back the results of testing. If we think about the survival of a patient diagnosed with advanced lung cancer, we're talking about months. If we are waiting a couple of months on sending out molecular testing and waiting for results, that is a significant proportion of the survival of a patient with advanced lung cancer. So to summarize, all non-small cell, all non-squamous cell carcinomas of the lung are sent out for molecular testing.
And Dr. Gutman, can you comment on whether or not your hospital has any kind of policy or how they deal with this 14-day rule when patients are diagnosed as inpatients? I know that it's not a large number, generally speaking, because most of these procedures are done as outpatients, but if one of your inpatients gets a lung cancer diagnosis, does the hospital wait to send out the tests, or do they usually send it out right away?
There is no waiting whatsoever. We actually have a significant number of inpatients that are diagnosed. Because of what I think is the success of our program, our hospitalists have become much more aware of following up these incidental lung nodules that may be detected during a hospital stay for another reason. They're much more aggressive in getting pulmonology consults and therefore biopsies. We have not had a problem with reimbursement of these tests, so I'm not exactly sure what other hospitals are seeing out there, but we have not had any problems with reimbursement, both from private insurers as well as CMS. So Medicare, Medicaid, we have gotten paid for these tests.
Okay. Well, thank you very much for those comments, and we'll sort of readdress some of those issues in just a moment. So I want to just mention that as we went and spoke with these different centers and talked with their teams, there wasn't always universal consensus on, for instance, the issue of reflexive testing. So most of them agreed that, they wanted to do that, but in some cases, there were some organizations where the medical oncologists still wanted to be the ones making the testing decisions as well as selecting which tests to order. So what we found was that whether it was around tissue acquisition or developing policies and procedures, that every organization had to consider their own internal culture, think about where that strong leadership was going to come from, given that in many organizations, even today in the community, there's still a lot of independent groups and private practices. So to establish that buy-in and the consensus and alignment on all of these issues still remains a process-related challenge. We also found that there was improvement opportunities to provide education around the different ways of biopsying. We got in some cases, all the radiologists sat down together and talked amongst themselves on how they were performing CT-guided biopsies, what size needles they were using, how many specimens they were collecting, just to see if there was an opportunity to get some kind of a standard operating procedure, as well as just really evaluating the use of certain things such as telepathology solutions, rapid on-site evaluation remotely, and those kinds of things. In pathology departments, there were several who commented that if they had better communication with either the medical oncologists or in some cases even those performing the biopsies, they may handle that tissue differently, especially if it's a histology specimen. They may try to preserve some more for testing, for biomarker testing, so that the way they modified their tissue handling procedures in some cases, was across the board, especially as they recognize the importance of molecular testing within their own institutions. So any comments on these points, Dr. Gutman, as you've either experienced it within your own organization or as you've seen other cancer programs in the country deal with these things?
Yeah, I would say, again, the issue of whether the oncologist has control over the order or not, as you said, I would suggest that each institution look at their own way of doing things. We decided that the pathologist would have the authority to reflexively order the test. I'm not sure which one is better or worse. It's the way that we decided to do to capture close to 100% of the cases that need molecular testing. The issue of tissue acquisition and processing, of course, it's very, very important. We do rapid on-site evaluations of CT-guided biopsies as well as EVIS, as well as the navigational bronchoscopy. The surgeons like to send us maybe one or two samples just to make sure that they are indeed close or at the lesion. So we do have that availability to do intraoperative consultations. Of course, I don't think that you absolutely need them to do this, but I think that it may lower the need to do extra CT-guided biopsies, for example. If after the first core there's enough tissue and the tissue looks diagnostic, then you don't need to do another 2 cores. But we have in some instances where a pathologist is not available, the radiologist will just go ahead and do 3 cores. And for the most part, if there's tumor there, they will have hit the tumor. So although beneficial, I don't think that rapid on-site evaluation is absolutely necessary. What I do think is absolutely necessary, and I believe I say this not just because I'm a pathologist, but because this is the truth, is that there has to be a very solid tissue processing protocol in pathology to make sure that that 1 millimeter in diameter core biopsy doesn't get cut through unnecessarily, that every single 4 micrometer slice of tissue is used wisely for diagnosis, for immunohistochemistry, and for preserving tissue for molecular testing. In our department, not everyone can gross these specimens, not everyone can cut these specimens, not every technician is allowed to get close to these specimens. There's special training for the techs that cut these type of tissues, and they're very much aware of the need to do very superficial cuts of the tissue and to preserve tissue for testing. This is becoming extremely even more important because once you're done with your first stage of molecular testing, that EGFR and ALK and possibly ROS1, down the road we're seeing more and more that oncologists are now asking for additional studies, maybe a Foundation 1 study, a Claris study. Again, what we were worried about 2 years ago, which was just that first line of molecular testing, now becomes an additional worry in the sense that we know that there's more molecular testing coming after that first round.
Great. Thank you very much. And I guess the other question that seems to be related to these policies, if you will, is that because you have a lot of different groups who have unique requests, when organizations are trying to develop institution-specific policies and communicate that out, how do you ultimately get buy-in, or is there a way to get buy-in, and can you just comment on that point?
Well, I believe, we were successful in getting that buy-in, and you participated in that success by being able to get everyone together in a room, and that includes everyone from the pathologists, the nurse navigators, the radiation therapists, the oncologists, the surgeons, the pulmonologists, administration, and agree that this was the way that we were going to move forward, that we were going to agree that molecular testing was important, that we were going to capture all the patients that needed to be tested, even if we were doing some additional testing on patients that at their stage of the disease would not need it at the present time. So yes, that buy-in is very important. That buy-in, I believe, can occur if all the participants are together at some point, if all of them have an input, and if all of them agree that everyone will have to sacrifice maybe some way of looking at things, but that ultimately there's a goal that benefits our practices and our patients. So yes, I believe that you cannot go into reflex pathology testing unless you have the buy-in of the specialties that are both providing you the tissue and the ones that will be using your diagnosis. So you need to get the people that get that tissue and the oncologists and secondarily the radiation therapists that will use the information that you provide them to agree on a protocol. I don't believe we would have been as successful with this as we have been if we had not had buy-in from all these different specialties.
Great. That's a great point. Yeah, and I think that what we have found over and over as we've talked with these different programs is that, they may have, for instance, standing cancer committee meetings and others, but they don't necessarily have all the different groups being represented. And so having a separate meeting, getting all the teams together, especially with administration, is really been a critical step in this whole process. I do also want to just continue and comment on the whole culture change towards continuous quality improvement or continuous QI, because what we discovered early on was when we were asking some of these questions up front on their baseline biomarker testing rates, some of the programs thought that, well, we can just find this from a registry, and then they quickly realized that, well, the registry doesn't have information about EGFR and ALK testing. So then it became now we have to look into each patient chart. And some of the programs even said, well, let's start adding the biomarker testing information into our registries so that we can periodically audit our performance, audit what we're doing, audit our procedures and policies. And so they really adopted and embraced this idea that this quality improvement has to be ongoing. It can't just be, all right, now that we've instituted this policy, we're done. We have to continually evaluate and assess where things might be falling through the cracks or where things may need to be improved, as well as the ongoing education and training. Several of these programs had staff members who had formal training in process improvement, while others did not. And so there was definitely ongoing interest in discussions and follow-up discussions around some of those areas where they wanted to invest in that process improvement training and the formal methodologies. Can you just comment in terms of how your program and how does Holy Cross, what is being done there in this area of continuous quality improvement, as well as the various training and the different projects that you all have going on?
Sure. So we quickly realized that if we were not able to quantitate what we were doing, we would probably just improve in some way, but as with many other improvements that are not followed up on, new people come on board, new techs come on board, new surgeons come on board, new pathologists come on board, people seem to forget or not learn what is being done. So we basically have the testing percentages as one of our quality indicators in the Department of Pathology. There may be other pathologists on this call or not, but to function as a laboratory, by CLIA, essentially, you have to have a performance improvement process in the laboratory, and you can decide, the medical director can decide which one of those, what elements are going to be incorporated in that process improvement. We decided that tracking not only the percentage of non-small cell, non-squamous cell carcinomas diagnosed with molecular testing was important, but we also tracked the turnaround time for return of the report. And the reason for that is that ordering can be very easy, but then making sure the report comes back, making sure the report doesn't sit for 2 weeks in a transcriptionist box and gets incorporated into the chart, that becomes a secondary issue that can become very important. So we expect a 10-day workday turnaround time for the pathology, the molecular report to be incorporated in the pathology report. And we are very specific about the molecular report being incorporated in the pathology report and not being placed somewhere else in the medical chart because, again, we do not know many times who the oncologist is that will receive this result. And in addition to that, that oncologist may not even be part of our medical system and has no access to our medical record system. So therefore, they will not get a full report if the molecular testing is not incorporated in the pathology report. So those were the steps that we took to sort of force and push the system to improve and then to be able to continuously monitor, just like we monitor another 20 elements of our laboratory's performance improvement.
Great, thank you. And it seems like especially in this era of electronic records and the whole interoperability issues that various organizations are dealing with, having that pathology leadership as well as having groups that are really being innovative and forward-thinking about how they can be more proactive to make sure that those results are being communicated efficiently seems to be more and more important. I know that as we talk to some of these programs, they wanted to incorporate part of these continuous quality improvement projects into their COC reaccreditation. In some cases, the medical oncologist said, hey, this would be great for our medical oncologists who are in the process of getting certified by the ASCO COPI program. So there certainly are a number of these projects out there, but I think our hope and our message is really to make sure that that culture really does shift so that it's ongoing, so that it's continuous QI, and that it's not just a single QI project. We do want to mention that there are definitely ongoing education and training resources available that have been published by various societies. Specific to those performing the biopsies, the American College of Chest Physicians offers a performance improvement module on the use of these advanced navigation or EBUS to diagnose non-small cell lung cancer, and that's on the chestnet.org website. And then the Society of Interventional Radiology also has published a quality improvement guideline for percutaneous needle biopsies. So these are resources that we certainly encourage everyone to make sure that their clinicians are referencing and using and following. And I think we are seeing that the country is in this evolving era of biomarker-driven therapies, precision medicine that's been launched, as well as this precision medicine initiative by the president. Lung cancer screening programs, many of these have emerged to detect earlier disease. So I think that the whole biomarker testing is going to become even greater and more important, not just in lung cancer, but in many other cancer types. And the reimbursement models, particularly focusing on this whole value, is shifting the conversation. And we know that ASCO recently released some guidelines and papers and some statements around this whole value issue in oncology. So we're going to see more and more happening there. I guess one question, and we're about to go right into the Q&A section because we're wrapping up here. But before we do, I do want to mention that on the ACCC website, under Provider Resources, keep your eyes out for the ongoing, something that's going to be mailed out with the July-August oncology issues called Ongoing Advances and Improvements in Molecular Testing. And it will be available on the website, as well as a number of other website resources around this whole biomarker testing space and lung cancer. In terms of the Q&A, one of the questions that came up, Dr. Gutman, is you had mentioned that your institution is not getting any barriers or seeing any issues getting reimbursed for biomarker testing in lung cancer, even though currently these tyrosine kinase inhibitors are indicated for patients with stage 4 disease. So just to clarify, if you send off, when you're sending off lung tissue and the patient has, say, stage 1, 2, or 3 disease, you're still being reimbursed for those EGFR and ALK tests. Is that correct?
We have not seen any problems in that regard, yes.
Okay. And as we've talked to different organizations, it seems like that's, for the most part, the same case. The Medicare 14-day rule, I think, is something that, and perhaps it depends on how it's processed, but we have heard from some of the organizations that has been an issue, although a number of hospitals have told us that they have just, as a hospital, decided that they're not going to wait to send off those samples. So I think it continues to be an evolving area. How about in terms of the reimbursement for some of these broader lung cancer panel tests? You know, you had mentioned Foundation, Caris, and others. Are you running into any kind of reimbursement issues related to those biomarker tests that are more, I guess, experimental or possibly more to identify patients for clinical trials? Any comments there?
We are not seeing problems with reimbursement in that regard either, no.
Okay. One of the questions that came up from the audience is when it comes to processes regarding the adequacy, going back to the adequacy tissue, and you mentioned that you have the rapid on-site evaluation. Is that being provided by a pathologist, a cytotechnician? Can you tell us a little bit more about how is that done, and how is that a checkbox that the either radiologist or pulmonologist selects, or do they call your department to schedule that? How is that? How do they get that rapid on-site evaluation?
Yeah, this is a very practical and important operational issue because pathologists, by the way, we don't have cytotechnologists, we don't have residents, we don't have fellows, so it's a private practice with staff pathologists. So for us, spending time next to the radiologist waiting for an adequacy, that does not really get reimbursed. The adequacy itself gets reimbursed, but the time does not get reimbursed. So if we're there 2 minutes, it's great, but sometimes you have to be there 20 minutes. So we came up with a compromise with the radiology department, and the compromise is the following. We will have a pathologist on site for all lung cases because of their fear of the risk of pneumothorax, and other complications. By the way, for lung cases, they do not do FNAs. We will not accept FNAs. We only do core biopsies. And we will also have a pathologist on site for any critical type of procedure where maybe they're biopsying a lymph node right next to the aorta and they don't want to do extra passes if not necessary. In all other circumstances, it is the radiologist that waits. That is, the radiologist does a procedure, let's say a liver mass. That is not, we don't consider that a critical procedure. So we do send a tech in that case to retrieve the specimen, and we look at it in our offices. So I want to break, this looks like a lot of detail, but I think it's important, especially in a community setting where you have private practice groups that need to make a living out of generating revenue, where I can understand a lot of pathology groups not being able to spend the amount of time on site at the radiology suite. So I would suggest that different hospitals, according to their volumes, according to their ways of practice, come up with some reasonable way in which there's a compromise. I think lungs are probably worth not having the patient wait for a tech to walk down the hall in a few minutes. So in that case, we have a little cart. We're right next to the radiologist, and we touch the core immediately and give them an adequacy statement.
Thank you. No, those are great insights, and it's a great point about, in terms of the hospital's practice and their staffing resources, as well as how the different pathologists interact with the various physician groups. So thank you for that response. Another question that came up is just regarding lung cancer screening. I don't know if you all have a screening program and if it's changed recently due to the Medicare announcement, but tell us a little bit about your lung cancer screening and how that's impacted the volume of just processing lung biopsies and what that's done to your department.
Sure. So yeah, we have been fortunate in our hospital to have had lung screening for the past 10 or 11 years. We've been a very active participant in the ILCAP, which is an international lung screening protocol that has been ongoing and is still ongoing for the last 10 or 11 years or so. So our radiologists are very experienced in screening. We do a substantial amount of screening under research protocols. Because of the changes in reimbursement and the ability to now charge for certain populations of certain ages and certain amount of smoking, etc., we have now moved to a quote-unquote revenue-generating screening protocol. I have not seen a significant increase in volume associated with the additional screening. We're probably screening maybe 10 patients more a month than we were screening before. Before we were screening maybe 20 patients a month. So I am not seeing the results of increased number of biopsies, and that's mostly due because the screening, what you pick up for the most part, are small lesions that are followed up 3 months, 6 months, et cetera, et cetera. Where we have seen an increase in the number of procedures that we have been doing, and therefore in the number of diagnoses, is with what we call our incidental nodule clinic. And again, I referred to that earlier, but we meet once a month with the thoracic surgeons and the radiologists and the pulmonologists and go over radiology reports where a lung nodule was found incidentally on a patient that was an inpatient for some other reason, maybe came into the emergency room or came in to be admitted for abdominal surgery, and the lung nodule was found. So there, in our population, it's about 600 beds. I would say we're picking up about anywhere between 10 and 15 quote-unquote incidental nodules a month, and we are seeing that 1 or 2 of those will go directly to a biopsy. That is, that they're a size or significance enough that the pulmonologist or thoracic surgeon believes that they need to be biopsied. That's been our experience so far, but as you can see, we're not doing massive amounts of lung screening, but we've pretty much increased it by about 33%.
Okay, great, thank you. And another question that came up is just regarding the whole process of performing the biopsy when something suspicious appears on an image, whether it's a CT or chest X-ray. Who determines whether they should be biopsied by a radiologist versus a pulmonologist? How is that decision made? Is it a team decision? Is it made by the primary provider? Can you just elaborate a little bit on that?
No. For the most part, in our system, they are made by the primary provider. And there's a lot of discussion back and forth about that. Our hospitalists are quite aggressive about biopsying nodules that they detect in our inpatient population. A lot of the primary care providers out there will order a biopsy directly. The thoracic surgeons, the pulmonologists, and the oncologists are not very excited about that. They would prefer to see the patient before, but the reality of the situation is that we get orders for a lot of these biopsies from, let's call them non-specialists. So the biopsy itself is the decision of whoever orders the biopsy, and then the referral to an oncologist or to a pulmonologist or a thoracic surgeon is also the decision of the individual that quote-unquote owns the patient or who's treating the patient. That the hospital really, or the hospital system, has no say in that. Again, we are firm believers in not hiring physicians. That physicians do very well in their own groups, and we try to keep that independence and support that independence. Okay,
great. Well, thank you very much, and we've run out of time, so I want to thank everyone for joining us for this webinar. And just as a reminder, on the ACCC website under Provider Resources, you will find a number of additional tools and resources and references to the learning labs, as well as ongoing advances and improvements in molecular testing that will be mailed out with the July-August oncology